Ulcerative colitis is a chronic idiopathic inflammation of the GI tract, which solely involves the large intestine, which is the colon. It comes under it comes under the major group of inflammatory bowel disease, which also includes Crohn's disease. So, ulcerative colitis was first discovered by Dr. Samuel Wills, in 1959. So, what really happened was that he was the first one to discover ulcerative colitis, and then there was a Mister named as Arthur Hurst. He was the one to completely describe ulcerative colitis, giving a more sigmoidoscopic appearance. And also, he explained that ulcerative colitis is very different from the bacillary dysentery. So, if we talk about ulcerative colitis, the location of ulcerative colitis, like I mentioned before, that it involves the large intestine. So, it has more of a distal picture. So, what really happens is that it involves the distal colon and a part of the sigmoid colon, and it involves the rectum. So, it involves the lining of all these colon and the large intestine. If we talk about the incidence of ulcerative colitis is present at any age, but before 5 and after 75, it's usually very uncommon. And the ratio between male and female is usually 1 to 1. Ulcerative colitis is mostly more present in the second and the third decade, more prominent in the 30s, the age group of 30s. So, ulcerative colitis is very unique in a sense that it is present in more developed countries as compared to underdeveloped countries, in people with a higher socioeconomic status. And other than that, if we talk about the industrialization, it has affected inflammatory bowel disease, and it has affected the development of inflammatory bowel disease. So, sanitation and exposure of microbiome and pollution has caused the development of inflammatory bowel disease. So, coming to the types of ulcerative colitis, the types are usually dependent upon the location of the disease. So, where exactly is the disease, the diseased colon? So, the names are dependent upon the location. The first being the ulcerative proctitis, which shows that there is the disease that is very confined to the rectum, as the word proctitis shows rectum. So the disease is usually just covering the rectum part, so it's called as ulcerative proctitis. The second type is called as the Proctosigmoiditis. So what really happens is that, as you can see in the picture, rectum is involved and the sigmoid colon is also involved. So the rectum and sigmoid as a whole is called as proctosigmoiditis. So what really happens, it gives more of an S-shaped disease state of the colon. Now, coming to the third type is called as the left-sided colitis, because as a whole, as you can see in the picture, more left side of the colon of the large intestine is involved, involving the rectum, involving the sigmoid, and involving the descending colon up to the splenic flexure. As you know, this part over here is called as the splenic flexure. So it is usually very, very confined only up to the descending colon. It does not reach up to the transverse colon, and so it's called as the left-sided colitis. Now, the fourth part is called as the extensive ulcerative colitis, because of the reason that almost all of the large intestine is involved, only sparing the ascending colon. As you can see, the transverse colon is diseased, the descending colon is diseased, the sigmoid colon, and the rectum. So it's almost covering the whole of the large intestine. So it's called as extensive ulcerative colitis. And lastly, coming to the final type of ulcerative colitis, it's called as pan-ulcerative colitis, which in other words mean that covering the whole of the large intestine. So these patients, they're usually very, very severe, as the disease has taken all over the large intestine, involving the ascending colon, the transverse colon, the descending colon, sigmoid colon, and the rectum. So these are the types of ulcerative colitis depending upon the location of the disease. So coming to the epidemiology, everyone would be wondering that what are the countries that are more affected with ulcerative colitis? So if we look at this picture of the world map, we can closely see that the parts of Africa, which is the light orange, they are the least affected countries with ulcerative colitis. As you can see, there are parts of the South Africa, and then there are parts of the North Africa, and then some parts of North America, South America. So these are the parts that are very, very have a very low percentage of ulcerative colitis within their individuals. Other than that, as you can see, as the orange gets more darker, around certain parts of Europe and around Russia and China. So they have a slightly more percentage of ulcerative colitis among their people. Other than that, as you can see, there are parts of South East Asia, they're having around 40 to 50% of their people, they do come up with ulcerative colitis. But talking about the people who are the countries that are majorly involved in the development of ulcerative colitis, these include mostly the West. So it includes Canada, and it includes North America. Other than that, certain parts of South America, and then there are some parts that some parts of Africa are involved, and majorly Australia is also one of the major parts of the world that is affected with ulcerative colitis. So as you can see, that more of the West and more of the white people, they're the ones who are mostly affected with ulcerative colitis. So coming to the causes of ulcerative colitis, everyone would be wondering that what are the causes of ulcerative colitis? How can a person just develop ulcerative colitis like that? And who are the people who are more prone to develop ulcerative colitis? So currently, the cause is completely unknown, but there are likely a lot of multi-factors that are involved in causing ulcerative colitis. The currently held paradigm involves a complex interaction of genetic susceptibility, host immunity, and environmental factors. So these three factors, they're all consecutively interactive, and one being it's not very necessary that one person has only the genetics problem and they develop ulcerative colitis. It's usually interactive. So a person having defective host immunity in a person having genetic in a person who's genetically predisposed, they usually lead to the development of ulcerative colitis. So coming to genetic susceptibility, so it is usually divided into two, having family history and some genetic mutations. So, if we talk about family history is one of the most important risk factor that develops ulcerative colitis. Around 10 to 20% of patients, they usually have one relative that also have ulcerative colitis. So, it's usually more common in patients who have first degree relatives. So, as you all know, first degree relatives would include your parents, including your siblings, and other than that, around a little less of the people, of the patients, they have a second degree relative who has ulcerative colitis. So second degree relative would include your uncle, your aunt, your cousins, your grandparents. So familial association is greater in those inherited people who are from the Jewish descent. This is very, very interesting in regard to heritage. So the lifetime risk of these people with Jewish descent, they have a risk of ulcerative colitis around three times fold more as compared to people with who are not from the Jewish descent. Other than that, it's very interesting to know that the US, they usually have the combination of parent-sibling combination who might share the disease. But other than that, if we talk about the United Kingdom, they usually have the patients usually share it with their siblings more as compared to their parents. So if we talk about gene mutation, ulcerative colitis is very, very specific to some of the chromosomes, such as 1, 7, and the chromosome 11, 15, 17, 19, and 20. So as you all know that there are different loci within the DNA. So what really happens is that there are around 163 loci that involve both of the ulcerative colitis and the Crohn's disease, which is the inflammatory bowel disease. So inflammatory bowel disease, they have around 163 loci involved. Around 110 of these are usually ulcerative colitis and Crohn's disease, so it has a combination of both the diseases. So a patient having these loci, these chromosomes, they tend to develop either ulcerative colitis or Crohn's disease. Around 23 of these people, they are very specific to ulcerative colitis. So having these loci, they usually develop ulcerative colitis only. That is more specific. And similarly, having 30 loci of out of these 163, they are more of a Crohn's specific. So in addition to that, if we see this is more of a polygenic disease. Like I mentioned before, there are a lot of chromosomes involved in ulcerative colitis, and the susceptible loci, like I mentioned, they are 1, 7, 11, 15, 17, 19, and 20. And positive family history, like I mentioned before, that family history is one of the main risk factors of developing ulcerative colitis. And they also have an association with HLA gene with this ulcerative colitis. Other than that, it's also very unique to see that ulcerative colitis does not follow the simple Mendelian gene structure, but it involves a lot of genes, and there are a lot of multiple genes that are involved in developing ulcerative colitis. So coming to the environmental factors, there are a lot of environmental factors that causes ulcerative colitis, that leads to the development of ulcerative colitis. There are a lot of infections that are involved in ulcerative colitis, such as a lot of bacteria, fungi, and viruses that also develop ulcerative colitis. Other than that, we've also seen that there's an implication in the pathogenesis, which depends upon the microbiota of the intestine. As you all know, that the microbiota is the good bacteria that is present in your intestine, in the lumen of the intestines. So they are the good bacteria, but when they get a chance to enter into the through the epithelial lining into the lamina propria, into the muscularis propria, so they develop a series of inflammation, and that would be the pathogenesis, which I'll be discussing further. So if we talk about the environmental factors, like I've told you, the commensal of enteric microbes, the good bacteria within your intestine. Other than that, infectious organisms could also be included, bacteria, viruses, and fungi. It's very interesting to know that people who smoke, they're usually they have a defensive mechanism against ulcerative colitis, which is very interesting to know. Among all the diseases in the medical field, ulcerative colitis is the one disease that is good in that seems a good thing in people who smoke. So it's usually because of the nicotine therapy. So what really happens, you know, that cigarette, they do have nicotine. So the nicotine therapy is good against the ulcerative colitis, and it gives a form of therapy that causes the symptoms and causes ulcerative colitis to suppress. There are a lot of different diets that are included in which makes a person prone to ulcerative colitis. This includes wheat, maize, fortified sort of foods, any additional separatives. Other than that, alcohol are very defective for people with ulcerative colitis. Interestingly, oral contraceptives, they also have a chance to develop ulcerative colitis. So it's a risk factor for those women who use OCPs. Food additives, like I've told you, mentioned before, any fortified food, they're also very harmful for people with ulcerative colitis. Very interestingly, toothpaste has also shown some studies have shown that toothpaste may also cause ulcerative colitis. And lastly, breastfeeding, not having a defensive mechanism, but it makes a lady more prone towards ulcerative colitis. Even we've also seen some studies that appendectomy also causes the patient to develop ulcerative colitis, which is very unique to any other disease in the body. So coming to the host immunity. If we talk about the different immune factors that are involved in ulcerative colitis, pathogenesis of ulcerative colitis emphasizes on the role of immune system within the body. So immune factors, they're usually divided into humoral immunity and cell-mediated immunity. So what really happens is that in humoral immunity, we've got increased plasma cells, we've got increased IgG synthesis. So being more specific, Ig1 and Ig3 is involved in ulcerative colitis. And other than that, Ig2 is very specific to Crohn's disease. So we've also seen the association of P-ANCA, which is one of the immune related microbiome. So what really happens is that PANCA is usually seen in patients with ulcerative colitis. Epithelial cells, we've seen that microbiome, they usually go through these epithelial cells when their adhesiveness is decreased, and they go through these epithelial cells and they develop a series of inflammatory response. Consequences of immune activation. Immune activation is processed, and what really happens there is the release of inflammatory cytokines such as TNF, IL-16, IL-12. And other than that, there are a lot of different psychogenic factors. So coming back to cellular immunity, cell-mediated immunity, this is also divided into innate and adaptive immunity. So innate, usually having our monocytogens, our lymphocytes. So they are the ones to produce pro-inflammatory cytokines. But other than that, if we talk about the adaptive immunity, which you all know that includes T cells and B cells. So what really happens, this mucosal lymphocytes, they usually are depending upon the location. So what really happens is that there are specific lamina propria lymphocytes, and other than that, we've got the intraepithelial lymphocytes, which usually are very defective, and this causes ulcerative colitis, leads to the development of ulcerative colitis. So if we talk about the pathogenesis of ulcerative colitis, the initial presentation of ulcerative colitis, there are around 45% of patients who come up with rectosigmoid specific ulcerative colitis, inflammation within the rectosigmoid. Around 35% of patients go beyond the sigmoid, and around 20% of patients have complete pan colitis, which includes the whole of the large intestine. So if we talk about the pathogenesis of ulcerative colitis, so this in this picture we can see this is the gut lumen, okay, and this is the microbiota. Microbiota is the good bacteria that is present within the lumen of the large intestine. And then we have these epithelial cells, and we have the immune cells, which is underneath the epithelial cells. So if we talk about the pathogenesis, there isn't a proper mechanism that can explain the link, the association between diet and the development of ulcerative colitis, but we're going to talk about it in a little detail. So if we compare between Mediterranean diet and any Western fast food sort of a diet, so what really happens is that the diet usually have a direct effect on the microbiome of the large intestine, and it has effect on the epithelial barrier function, like the epithelial cells, and then it has an effect on the immune cells, which is the immune function. So what really happens is that if a person has a diet that consists of fruits and vegetables, whole grains, and seafood, which is a healthy diet, so it causes a diversity in the microbiome. So a good diversity of the good bacteria within the lumen is very, very helpful for the individual. But other than that, having a barrier function, which is an intact permeability, which does not allow any foreign microorganism or any foreign antigen to enter through the epithelial cells. This is a good thing. So a good diet helps us with that. And other than that, lastly, it has a direct effect on the immune function, that it causes a balance between the tolerance versus the inflammation. So there's a balance between the T regulatory cells, and there is a balance between the T helper cells. So this is a record of a good healthy diet. So if we talk about Western diet, which includes red meat, processed food, refined sugar, and saturated fat. So what does it do with all these to all these features? So the microbiome, it causes dysbiosis, that there's an individual part of the bacteria involved. So there isn't a very good diversity between the bacteria and the microorganisms. Other than that, it causes an impaired permeability. So it completely destroys these tight junctions between the epithelial cells, and it causes a vast permeability. It causes lots of things to pass through the epithelial cells. And lastly, it causes a loss of the tolerance. So tolerance, as compared to the inflammation, goes into an imbalance. So the tolerance is decreased as compared to inflammation, and then there's an increase in inflammation. So this causes the predisposition into an inflammatory bowel disease. So there's inflammation throughout the lumen, throughout the vasculature. So in this picture, it gives a more detailed review of what really happens. So what really happens is that the mucinous layer. So this is the outermost preventive defensive layer of the large intestine. So it comes in the first physical separation between any microbiome that enters through the epithelial cells into the lumen. So what really happens is that if there is a decrease in mucin, so decrease in mucin causes an impaired mucinous layer. So what really happens is that when there's a decreased mucin, the mucin layer is impaired, and there is a defective regulation of the tight junction. So the tight junctions between the epithelial cells is completely destroyed. And so what happens is that these microbiome, the antigens, these are the antigens of the good bacteria that are present outside the lumen. So these good bacteria, they supposedly should be present within the lumen. They're not supposed to enter through the epithelial cells into the lamina propria or the muscularis mucosa. So when there's an distortion between the tight junctions, distortion, and there's an impaired impermeability. So what really happens is that these antigens, they come through the epithelium into the lamina propria. So how do they really come through? What really happens is that we've got these activated dendritic cells and activated macrophages. They spread out their TLR receptors and they catch these antigens, and these antigens are then these are the antigen presenting cells that they bring these antigens into the lamina propria. So next what happens is that there is this nuclear factor kappa light chain B cell that processes these microbiome, these antigens, and they produce a variety of cytokines, such as pro-inflammatory cytokines, such as TNF alpha, interleukin 12, 23, 6, and interleukin 1 beta. So what really happens is that they transfer these pro-inflammatory cytokines to the cells which are the naive T cells or the CD4 cells. So they start to produce interleukin 4, and then the interleukin 4, they are produced with the help of effector Th2 cells. And other than that, we've also got the natural killer cells that produce interleukin 3 and interleukin 5. So these cytokines, this reaction, this causes a cycle of the pathogenesis. So this interleukin 3 and interleukin 5 and interleukin 4, they causes disrupted epithelial barrier. So as you can see in this diagram, this causes a cycle to emerge, and the cycle keeps on happening. The epithelial barriers again disrupted, then there's the antigen microbiota and antigen coming into the lamina propria, and then the antigen presenting cells, they're again producing the interleukin pro-inflammatory cytokines. So this vast cycle keeps on happening, and then there's an inflammation of the lamina propria. Other than that, if we talk about the systemic circulation, what happens within the microvasculature? These circulating T cells, they attach to the endothelial cells within the vessels, and they produce the recruitment of leukocytes. There's an upregulation of CXCL1, 3, and 10, and they also cause the recruitment of leukocytes, and these leukocytes, they then initiate the cycle of inflammation. So there's an inflammation even within the microvasculature, within the vessels that that is in contact with the lamina propria. So as you can see, there's a whole process of inflammation that occurs because of this kind of pathogenesis. So if we talk about the macroscopic picture of ulcerative colitis, we can see that there might be edema, there might be inflammation, there might be any sort of erythema, and ultimately hemorrhage and ulcers occurs. And so that is why patients usually they present with occult blood with within their stool. So in this picture, we can see that this is a macro picture. This is a specimen from a patient with ulcerative colitis after having has his colectomy done. So what really happened is that the arrow over here, it shows the terminal ileum that is normal. So this part is all normal. And other than that, we can see that the colon extending from the transverse colon, the descending colon, sigmoid colon, and the rectum, they're all inflamed and erythematous. As you can see, a clear difference between the normal and the abnormal colon. Other than that, this is a more close-up picture of a patient with ulcerative colitis who has had colectomy done. So this is a specimen of the colon, we can see the most distinguishing feature that we can see in this colon is the presence of pseudopolyps. So as you can see, a lot of pseudopolyps that is present within the large intestine. So the problem with pseudopolyps is that even after having the inflammation ablated and even having the colon to heal out, these pseudopolyps, they persist and they remain within the colon even after having the treatment done. Other than that, we can, if we talk about the more microscopic picture, we can see congestion and edema of the lamina propria in the next pictures that I'll show. This is a picture of the lamina propria. As you can see, that there is an inflammation of the lamina propria, and the crypts of the large intestine are completely destroyed. And another picture, we can see that this is a distorted picture of the crypt of the colon and the presence of a lot of polynuclear neutrophils within this ulcerative colitis patient. So the other picture of microscopic picture of ulcerative colitis, in this we can see that there is a base of a colonic crypt which is completely distorted, and there is a presence of plasma cells, a variety of plasma cells between the crypt and the muscularis mucosa. So this completely shows the inflammation within the ulcerative colitis. So, if we talk about the clinical features of ulcerative colitis, how can we suspect a patient who comes up in the OPD with symptoms of ulcerative colitis? How can we suspect that this is the patient who might be having ulcerative colitis? So, what really happens is that there is a variety of symptoms that a patient can present. A patient might present with diarrhea, which is very common in inflammatory bowel disease. Patients with Crohn's disease also have diarrhea, and ulcerative colitis also have diarrhea. So there's diarrhea, there's rectal bleeding. There might be bleeding with the stool, and other symptoms such as urgency. The patient has to go to the washroom. Other than that, we can see there is tenesmus and abdominal pain that a patient might present. Other than that, there is in a more severe patient, we can see they might be having fever and weight loss. So we've listed a few of the clinical features, symptoms that a patient might present. One is the fever. Second is the patient might feel very tired. Patient might feel fatigued. The patient might present with irritated and reddened eyes. Mouth ulcers can be present. They're also called as aphthous ulcers. Weight loss, like I've mentioned before, in a more severe disease, patient might present with loss of appetite because of going to the bathroom so many times, having episodes of diarrhea. The patient might also present with extra intestinal manifestations such as painful and swollen joints, arthralgia, myalgias, and abdominal cramps, abdominal pains, and there might also be some dermatological features such as areas of red and swollen skin. And lastly, we can see, like I mentioned, recurring diarrhea, needing to empty the bowels more frequently, rectal bleeding, and rectal mucosa. So the patient might also notice some mucus present within his stools. So, if we talk about the signs, what are the signs that a doctor is going to be seeing in a patient with ulcerative colitis? Patients might present with mild or severe disease, and they may exhibit different types of signs. So, we'll be talking about those signs more in detail. The patient might present with a difference in weight and height, like I mentioned before. A more severe patient might present with weight loss. Other than that, if we do the examination, the abdominal palpation, we can notice tenderness within the abdomen. And other than that, bowel sounds are usually more normal, but in a severe case, we can also notice that the bowel sounds are more pronounced. Other than that, like I mentioned before, patient might present with aphthous ulcers. They might also present with clubbing of the fingers. And lastly, peripheral edema is also one of the features that a patient might present because of the presence of hypoalbuminemia. So if we talk about clinical features, a doctor must have had a digital rectal examination done. So when he has done the digital rectal examination, he might notice that the rectal mucosa feels a lot more velvety and may feel edematous, may feel inflamed, and the patient might present with pain. Whenever the examination is being done, the patient might complain that it's tender, it's painful down there, so the anal canal might be tender. And other than that, when the doctor he removes out his finger, he notices blood on his finger, so there's a presence of occult gross blood within the ulcerative colitis. So this is one of the macroscopic feature that we can see, which proves that it's more of a severe case. So if we talk about the laboratory findings, usually the laboratory findings is non-specific, but the patient might present with the patients with active extensive disease or more severe disease might present with the following lab findings. The patient might present with anemia because, like we've mentioned, that the doctor might see blood within the digital rectal examination. So it might be possible that the patient is bleeding from his large intestine, and that has led to anemia. Other than that, because of the possibility of microorganisms, bacteria, viruses invading, the patient might have his WBC count raised, and there might also be thrombocytosis. Other than that, there is a possibility that potassium levels are low, and metabolic alkalosis is also one of a feature of ulcerative colitis. The blood urea nitrogen level, which is called as the BUN, is also increased, and creatinine can also be seen if the patient has had his renal function test done. Hypoalbuminemia, like I've mentioned before, if the patient has peripheral edema, this might be the reason why. There might be an increase in aspartate aminotransferase and alkaline phosphatase. So a patient should have his LFTs, liver function test, done. There is an increase in ESR and C-reactive protein, and lastly, there is a necessity to have his fecal stool test done too, and we might find fecal calprotectin within the stool tests. So, if we talk about the natural history and the prognosis of a patient with ulcerative colitis, so 80% of patients with ulcerative colitis have a disease that is characterized by intermittent flares within having a remission period. So, a patient might be in remission, but there might be chances that there are flares of the ulcerative colitis disease. So around more than 50% of patients are usually mild. If we talk about ulcerative colitis categories, and around 6 to 19% of patients have severe disease. So this is a graph that shows, that explains a patient being in remission and a patient having active disease, and those patients who have had colectomy done. So this is the percentage of patients from 0 to 100. And then on the other axis, we've got the years after diagnosis of ulcerative colitis. So If we specifically talk about remission, there's around 50% of patients who have had remission. So, remission is a period in which the patient may be in a period where there's a complete disappearance of the symptoms regarding ulcerative colitis. And around, as you can see, there's around 20 to 30% of patients who develop active disease, and around um, 20 to around 25% of patients they've had colectomy done. So this is a prognosis chart. Other than that, if we talk about the probability, the percentage of how a patient might present. So in this graph, we've got the probability as compared to the percentage, and then years after diagnosis of ulcerative colitis. So what really happens is that a patient having relapse and having a flare, there are around 90% of patients who have the probability to have a relapse and a remission and a flare course. Other than that, if we talk specifically about a single flare, around 10% of patients, if we talk about later years, they have a single flare, around 10%. And continuous activity, if we talk about the disease that is just continuous without any relapse, without any flare, those patients have around 1% or 0.1% chance probability of having a continuous activity. So, if we talk about today's lecture, what have we really studied? We've started off with the definition of ulcerative colitis, what really is ulcerative colitis, and what are the parts of the large intestine that are involved within the disease of ulcerative colitis. Other than that, we've studied about different etiological factors. What are the factors that that causes the development of inflammatory bowel disease, which is more specific ulcerative colitis? A patient might be having environmental factors, or maybe it's within his genes. He has a family member who has had ulcerative colitis. Other than that, we've studied that what are the different pathogenesis that causes ulcerative colitis. We've studied about the epithelial junctions being disruptive, and then the dendritic cells in the macrophages that causes the pro-inflammatory cytokines to cause a complete inflammation within the large intestine. And then we've studied about different clinical features. How can a patient present? How can we suspect a patient having ulcerative colitis if he has come up to the outpatient department? Other than that, we've studied about the different lab investigations that we can do. We've seen a macroscopic picture of ulcerative colitis, and we've seen a microscopic picture of ulcerative colitis. So we've distinguished the differences between the both, and we've seen the prognosis and the history of a patient, how do they present. So we'll be studying about the investigation and the management of ulcerative colitis in the next lecture. So I hope you've enjoyed this lecture. Keep watching sqadia.com, and thank you for watching.